Yeah, okay.
Good evening to all my respected and fellow presenter and participant. It's a great honor for me and my pleasure to be here today to present about this topic when vomiting is more than hangover, a near-miss Boerhaave syndrome, which prepared by me and also the co-author, Dr. Lai Xin Nan. Okay, everyone can hear me? Can everyone hear me?
Yes, ma'am.
Before further discuss about the case, I would like to discuss about the background and introduction of Boerhaave syndrome. Why is it important? Boerhaave syndrome is a spontaneous full-thickness esophageal perforation. It's a emergency. It's rare but a life-threatening condition. What would we say so? As we can see here, after the full thickness of the perforation of the esophagus, the content leak into the pleural space which further causing mediastinitis and also pneumonitis. This is a very rare incidence with a global incidence of 3 cases in 1 million population per year. And it's usually triggered by forceful vomiting or any other activity that cause sudden increase in the intra-abdominal activities, such as giving birth, such as sudden heavy lifting. Any delay in diagnosis will greatly increase the mortality. Okay, why is it clinically important? Okay, as we can see, chest pain is one of the most common presentation in emergency department. It's accounted for 5 to 10% of all the ED visits. GI causes is less common among them because the cardiac causes remain as a predominant etiology of all the chest pain presentations. Okay, the diagnosis can be challenging based on the study. The classical marker triage will consist of chest pain, vomiting, and also subcutaneous emphysema might not present all together in this scenario, which only occur in 14 to 25%. Okay, if left untreated, the mortality rate can reach up to 40%. However, with early intervention and treatments in 24 hours, it can significantly improve the survival rates. So here comes to the case discussions. Okay, this is a 34-year-old gentleman presented to our emergency department with a complaint of chest discomfort, shortness of breath after vomiting for multiple episodes. So prior coming to emergency department, he was reported consuming alcohol, which mixing beer and also hard liquor. When arrival, patient alert and conscious, hemodynamically stable without sign of any shock. So initially, we are treating him as alcohol intoxication with lactic acidosis. And after some IV drip hydrations, we can see that patient clinically improved and also the lactic acidosis was improved as well. This patient was then discharged home. He came back with a worsening dyspnea and chest pain in 12 hours. Okay, so an urgent bedside scan done was noted there is some pleural fluids in the lung field. And after that, he was immediately referred to the respiratory team and chest tube insertion was done and was noted turbid fluid drainage into the under water seal system. During the admission, because we are initially thinking is pleural effusion, we optimize the oxygen up to a high flow cannula level and also the fluid resuscitation. He had persistent hypoxia and also lactic acidosis. Throughout the admission, we can see they still having some purine discharge over the chest tube drainage. So there are a few serious chest X-ray was done throughout the admission. On arrival, before chest tube was done, we can see there's a massive less vessel opacity. Okay, well, after the chest tube insertion, we can see that drainage it become better, but patients start to develop a persistent bilateral pleural effusion with unknown origin. Okay, so the next step when we monitor in a high dependency unit, we can see that despite with our ongoing chest tube drainage, the bilateral pleural effusion still persistent and recurrent. So patient was then arranged for a CT thorax. Okay, so based on the CT thorax, we can see this is a normal lung field, but the left lung field, there is a mediastinal air from here, and also some contrast leak, and it compressed over the lung tissue. Hence, patient was then confirmed having the distal esophageal perforation. Okay. Subsequently, this patient was then referred to upper GI specialist to do esophageal repair and as well as esophageal stent. Patient was then started broad spectrum antibiotic and also antifungal. Okay, so the discussion point of this case discussions. Okay, so we can know that the early diagnosis of this Boerhaave syndrome remain challenging due to its non-specific and misleading presentation. Sometimes it can mimic a cardiac condition. Okay, so the marker triad that, as we mentioned before, is rare. It's only occur in 15 to 24% among all the cases based on study. Okay, so with the absence of this subcutaneous emphysema, sometimes you can lead to a misdiagnosis and a premature diagnosis, and hence leading to a delay treatment. So, role of imaging carry a major roles here. Initially, as compulsory, where you doing chest X-ray for all the patients with chest pain, sometimes it may show pleural effusion with a fluid over the lung and pneumothorax, but sometimes it's subtle and non-specific. Okay, the bedside POCUS scan can help us to detect the pleural effusions efficiently and trigger a further investigation such as a CT contrast. Okay, CT thorax with contrast remain a high sensitivity with a 92% to 100%. It has a benefit of detecting site of esophageal perforations, contrast leak, or any pneumomediastinum means any air over the mediastinum. Okay, so what are the acute steps that can be carried out in an acute setting? Okay, so we must make sure the patient is new by mouth, okay, and also with adequate fluid resuscitations to prevent patient go into the shock and provide oxygen support. Okay, we should start a broad spectrum IV antibiotic and antifungal therapy, and also our PPI to protect the acid production from the gastric. And also, if let's say patient having a respiratory compromise, it require a chest tube insertions immediately. And last but not least, this is the most important one. We should have urgent surgical referral and surgical interventions because timely management should be done since the early phase. Okay, so the conclusion and key take-home message from my case presentations. Boerhaave syndrome is life-threatening condition, yet it's very rare. It's only happen in 1,000 population per year, but any delay in the diagnosis increase mortality and complication. It can cause a severe bacterial infection over mediastinum and also lung field. And so we should maintain a high clinical suspicions in patients which has spent dyspnea after forceful vomiting. And also, if patient presented with pleural effusions and there is unexplained respiratory deterioration despite we already optimized the oxygen. So earlier thoracic imaging, such as CT thorax with a contrast, is essential to enable timely diagnosis and definitive management. Okay, these are my reference, and thank you for your attentions. Any other questions from audience?